Good morning. Sorry that not being able to demonstrate live keraprosthesis surgery for you this morning, but I will explain to you why I am not. And I think honestly that you will get more out of this 5 or 10 minute discussion than you would watching me suture. At least that's what my fellows would tell you. So we were going to have seen a case. I want to present a case to you of the gentleman who I saw yesterday, who was our candidate for K-Pro surgery, a 73-year-old gentleman with decreased vision and irritation in the right eye. He has a history of trauma to the right eye with limbal stem cell deficiency. He had an amniotic membrane transplant performed in 2009, a corneal leucoma that was managed with phototherapeutic keratectomy and a conjunctival limbal autograft in 2010. He was then diagnosed with a suspicious conjunctival lesion and underwent an excisional conjunctival biopsy. It was positive for CIN, amniotic membrane transplantation again, and another conjunctival limbal autograft. The patient also was treated with topical mitomycin C. He subsequently developed a dysmetacel in his right eye and underwent a lamellar keratoplasty and amniotic membrane transplantation in 2015. He then developed a dense cataract, persistent epithelial defect, which led to donor stromal necrosis, and has anterior and posterior synechiae, so underwent a penetrating keratoplasty, intracapsular cataract extraction, and lysis of iridocorneal adhesions in May of last year. The patient then unfortunately developed repeat corneal transplant failure. So on exam, in this right eye, he's hand motions, but in the left eye, he's 20/20, or 6/6, with a plus 0.50 diopter sphere refraction. The pressure in the right eye measured yesterday was 9 millimeters of mercury, but the globe was very deformable with your finger. When you lift up his eyelid, the whole globe sort of indented. So I think that that pachymetry, which was probably 900 microns, was making the intraocular pressure measurement higher than it really was. I think his pressure is probably more like 5 to 6, normal axial length. So here's a photograph of the patient. Obviously, the right eye is the eye that has had this long history, ptosis. The left eye appeared normal to slant examination. He's still phakic in the left eye. Anterior segment photograph of the right eye. You see here the failed graft. He has vascularization of all 4 quadrants. He has a persistently dilated pupil with complete iridocorneal adhesions. I didn't see necessarily a retrocorneal membrane on exam, but I wouldn't be surprised if there were one. And on B-scan, it appeared fairly normal, the posterior segment. So it's early, but we're going to vote here on how would you manage this patient. Not necessarily if you're asked to do live surgery, but if you see this patient in your practice next week, what are you going to do for this patient? The options are Boston keraprosthesis, type 1, a repeat penetrating keratoplasty. Again, he's had a penetrating graft and a lamellar graft. A DSEC underneath this failed penetrating keratoplasty, or observation. So how many people here, by show of hands, would do a Boston type 1 keraprosthesis? Nobody. So if I had been doing live surgery, well, Joseph, okay, we have one. Dr. Well. So if I had been doing live surgery, you're the only one who would not think, what in the hell is he doing? The rest of you would be saying, why is he doing a K-Pro for this patient? How many would do a repeat penetrating keratoplasty? With total iridectomy, okay, to ensure that he's photophobic. Okay. I'm kidding. I'm kidding. How many would do a DSEC? I thought you were going to say DSEC. One DSEC? Okay, brave man. He likes to have heartburn. How many would just observe? Okay. No APD, no reverse APD. Observe until he dies. I'm not going to tell you. I don't know if there's a right answer. But that's why we're here. I mean, I think this, again, is probably a more interesting discussion than just having watched me do this surgery. So we have a patient here who has good vision. He's 20/20 in one eye. Does it ever make sense to do a keratoprosthesis in a patient who has, let's say, repeat graft failure in one eye, but 20/20 vision in the other eye? I don't know about our panelists. I certainly have done it, but for me, there are criteria that should be met to do that. How about improving peripheral vision? If this gentleman says, I'm driving and I cannot see off to one side, do you think a keratoprosthesis would be indicated there to give him better peripheral vision if he's still driving? Okay, well, that's been looked at. This is a figure from an article published by Dr. Dolman and colleagues 2010, excuse me. We're looking here at the binocular visual field. In the dotted line here is a visual field for a right eye of the patient in which a keratoprosthesis has been placed. And if you look at the horizontal meridian, that patient regained 90 degrees of vision in the horizontal meridian. Pretty good. Remember, normally about 120 degrees. So the K-Pro doesn't really limit the horizontal visual field that much. However, the solid line is the normal left eye in that visual field. And you'll notice that in the eye with a K-Pro, the visual field lies almost entirely within the visual field for the contralateral eye. So doing a K-Pro to improve peripheral vision does not work. It is not a good reason to do a keratoprosthesis because it does not expand the binocular visual field. So you've got to have a better reason to do it in a patient with good vision in the other eye. What about to provide binocular visual acuity or stereopsis? Can a patient regain stereopsis if they have a K-Pro implanted? We looked at that a few years ago with our colleagues on the Pediatric Ophthalmology Service. I looked at about 20 patients of mine who had good vision in one eye and then had a K-Pro in the contralateral eye. And we measured first-degree fusion, second-degree fusion, and then third-degree fusion, or true stereopsis, both at near and at distance. For 17 of the patients, we had all the data points. And you'll notice, for the patients who regained third-degree fusion, it's 7 out of 17. This is the eye with the K-Pro. Only one of them had vision less than 20/50. So by and large, if you're going to regain stereopsis, the visual potential in the eye with a K-Pro has to be 20/50 or better. And that really excludes most of these patients who are coming to you with multiple failed grafts because they usually have glaucoma and other comorbid conditions that may limit the recovery of vision. So third-degree fusion typically achieved only in patients with corrected vision 20/50 or better after K-Pro implantation. So in this gentleman, it's unclear. You ask him how well did he see after the lamellar keratoplasty, how well did he see after the penetrating keratoplasty. Well, after the lamellar keratoplasty, he wasn't able to read in the right eye. After the penetrating keratoplasty, remember, he was left aphakic. So he never had an aphakic correction placed before the graft failed. So he has unclear visual potential, but I would guess based on the hypotony, based on his history, it's probably not 20/50. And that's why I decided not to do a keratoprosthesis for him, even though he came a great distance and you all wanted to see. I know you're here only because you wanted to see a keratoprosthesis this morning. All right, so and one other reason for this gentleman is because he has a history of recurrent corneal necrosis. If you put in a prosthetic device in his cornea, now he is stable, the ocular surface is stable, but you could trigger inflammation in the cornea and may increase, probably would increase his risk for developing recurrent corneal stromal necrosis. So I think in this case, better to leave him alone. What about penetrating keratoplasty for this gentleman? Well, if we think about what are the likelihood that this transplant, if we do a third penetrating keratoplasty, will be clear, let's say 3 years after surgery. If we look at this article, which examined the outcomes of repeat penetrating keratoplasty, a third transplant would be this dark, heavy line. We can see at 36 months or 48 months, the chance of that graft surviving is less than 20%. So if you do a penetrating keratoplasty for this patient, he has to understand that there's less than 1 in 5 chance, probably, of that graft being clear 3 to 4 years after surgery. Now, this patient has irritation due to microcystic epithelial edema. So he's also wanting to know what can be done for his irritation in addition to his decreased vision. And the question for you is, if the patient's corneal edema is secondary to hypotony, then you wouldn't want to do a penetrating keratoplasty or a DSAC, right? Because those grafts are going to have the same problem as this graft. And so the question is for the audience, is this edema due to hypotony or endothelial failure, or how do we know? Did everybody hear this? All right, Dr. Terry says it is exactly right. You do not get epithelial edema from hypotony. If a cornea is edematous due to hypotony, you do not get epithelial edema. And that's one of the, I think, the most important things we can teach our fellows and residents when they're evaluating patients who have a failed graft or corneal edema, when a softer eye, trying to decide, is another graft indicated? Because if they have hypotony, pressure of 3, no epithelial edema, that next graft will probably not function as well. In this case, he has irritation from epithelial edema, so we know then that his dysfunction is not from hypotony, so we could consider a repeat PK for him. The question is, of course, do you suture in an IOL in a case like this? My preference would be to do one. I think if you're going to the operating room, you should probably go put an IOL in, because a 73-year-old patient is not going to start learning to wear an aphakic contact lens, especially with good vision in the other eye. He's never going to wear an aphakic contact lens. DSAC. This gentleman in the front would consider it. I don't know where to send my patients now. You know, DSAC, of course, for failed graft is, I think, a lot of our preferred techniques now. A lot of us are doing DMAC for graft failure. But those are grafts that we know had good topography, low astigmatism, patients who were happy with their glasses-corrected vision prior to graft failure. In this case, the patient didn't have a topography prior to graft failure. We don't know what the topography would show. Also, of course, he is aphakic, essentially aniritic. So you can do DSAC here, but high risk of posterior dislocation. You could suture in an IOL, but it's a lot of work in combination with a DSAC. Be much easier if it's done open sky. So the decision in this case was to just observe. And that's explained to the patient. He asked about his irritation. I explained because his conjunctiva was not mobile, amniotic membrane transplant with or without micropuncture may relieve his irritation, would not improve his vision, but at least achieve one of the aims of his coming here to see us. So again, I apologize for not being able to demonstrate live surgery. Hopefully I'll be able to do it at a future meeting, because I do like doing keratoplasty surgery and trying to encourage my colleagues to also embrace it. I don't know if Dr. Balistrazi is here, but if he is, I want to thank him so much. I sent so many emails to him, asked for so much information regarding the K-Pro candidates. He was very patient with me. Is Enzo here? He had a long night, so I don't blame him if he's not, but he's been an incredible host. I want to thank Dr. Dolman. Dr. Klaus Dolman, many of you know, of course, who he is. He gave me 2 keratoprostheses to use here, and so I am going to give them to SICSSO as a gift from Dr. Dolman. So we can, you can talk to Enzo. He'll probably sell those to those in the audience who would like one of these K-Pros. Now, Dr. Dolman gave them to me under the assumption I would be using them for live surgery. So if any of you talk to Dr. Dolman, don't tell them I didn't use them, okay? Tell them that you loved the live surgery, the most beautiful K-Pro case you've ever seen, so he doesn't ask for these back from me. So I want to thank all of you for your attention and thank the panel.